we are discussing cardiovascular system, right? I don't think this mic is required at all because only few students are here. So we are dealing with cardiovascular system, and we have started with ECG, right? We have started with ECG. We have talked about the details of ECG. Okay, although ECG practical is yet to be done, that will be covered in your practical classes. We will be actually doing ECG of not of a patient right now. We will be doing ECG upon your batchmates, right? Okay, so we'll perform ECG, and that practical class is remaining, right? But all the theoretical aspects of ECG, how to read an ECG, how to the development of ECG, the ECG leads, everything has been discussed. Normal ECG has been discussed, and now I told you that 3 abnormal ECGs you need to know, right? 3 abnormal ECGs. One, it is acute coronary syndrome. Traditionally in layman language we call it heart attacks, right? So to interpret an ECG with acute coronary syndrome, either ST segment elevation or ST segment depression, and what are the physiological basis of ST segment elevation and ST segment depression, we have talked about, right? Second abnormal ECG, what you need to know at first professional MBBS is heart block, right? And we have discussed AV block. Under AV block, we have discussed first degree heart block, second degree heart block, and third degree heart block, if you remember. And also we have discussed few conduction blocks like right bundle branch block and left bundle branch block, and what are the ECG changes in right bundle branch block and left bundle branch block, right? These things we have discussed, but the remaining part is another important abnormal ECG that you should be able to interpret is the arrhythmia. Okay, what is arrhythmia? Arrhythmia, simply the name suggests arrhythmia. That means there is disturbance in rhythm. Okay, there is disturbance in rhythm, right? Okay, so to talk about disturbance in rhythm, we will start with the tachycardias, right? The tachycardias, you know, by now I guess you all know what is tachycardia and what is bradycardia. Tachycardia is consistent heart rate more than 100 and bradycardia is less than 60. Okay, to define bradycardia and tachycardia. Okay, so what are the causes of tachycardia, right? So what are the causes of tachycardia? Tachycardia ki karon ache, right? So first of all, sinus tachycardia. Sinus, that means rhythm is essentially being generated from SA node and the rate is more than 100. Say for example, you are in excited state, right? Or you are frightened, you are in a stressful condition, your heart rate just before the exam, say for example, your heart rate is increased, sinus tachycardia more than 100, right? So absolutely there is no issue, it is not a disease, right? Okay, then atrial tachycardia, that means some focus within the atria which is generating impulse. Normally your SA node is supposed to generate impulse. From SA node action potential is generated, right? It is the pacemaker cell, but in an abnormal situation, it might be a situation where SA node is actually not working, but some other atrial tissue which is playing the role of pacemaker tissue. Okay, not SA node exactly. Okay, maybe any atrial myocyte. Okay, so it may be a single foci or a single point jahan se rhythm generate ho raha hai, or it may be multifocal as well. Okay, so we call it multifocal atrial tachycardia or single focal atrial tachycardia in this way. Okay, all are supraventricular tachycardia. There may be junctional rhythm. Junctional rhythm means not from atria, not from ventricle, from in between, AV node. Okay, yahan se rhythm aa raha hai, right? AV node is taking the role of pacemaker, right? So these are all abnormal situation. Okay, but we are focused here to discuss some tachycardias which are due to re-entry. Okay, so again I am giving you the tachycardia, causes of tachycardia. One is sinus tachycardia. So we are discussing tachycardia, right? Tachycardia, sinus tachycardia. Okay, single focus atrial tachycardia, then multifocal atrial tachycardia or MATS. Okay, 4 junctional rhythm, 5 re-entry tachycardia, 6 atrial flutter and atrial fibrillation. Okay, so these are different types of supraventricular tachycardias. Supraventricular tachycardia means it is a tachycardia where the rhythm is coming from above ventricle. सुप्रावेंट्रिकुलर टैकीकार्डिया, सुप्रावेंट्रिकल मतलब वेंट्रिकल के ऊपर जो है, क्या है वेंट्रिकल के ऊपर एट्रिया है, राइट? सो सुप्रावेंट्रिकुलर टैकीकार्डिया मतलब rhythm is coming from above the ventricle. Okay, pacemaker is somewhere located somewhere above the ventricle but not the ventricle. Okay, तो normal SA node से rhythm generate हो सकता है, तो we call it sinus tachycardia. And I have given you an example just before the exam what happens, right? So this is sinus tachycardia, this is normal, absolutely physiological, right? Then single focus atrial tachycardia, other than SO node, some atrial myocyte is beating, right, or initiating the beating, right? Then multifocal atrial tachycardia, junctional tachycardia in between atria and ventricle, re-entry tachycardia, we will discuss it right now, and atrial flutter and atrial fibrillation. Okay, we will cover this in the subsequent discussion, right? Okay, now you will focus on the fifth, that is re-entry tachycardia. Okay, tachycardia which is being generated due to re-entry, right? It is not single focus atrial tachycardia, it is not multifocal atrial tachycardia, but some sort of tachycardia, it is not atrial fibrillation or it is not atrial flutter. Some tachycardia which is being generated due to re-entry, due to re-entry. Now, ये re-entry क्या होता है? ठीक है? Next question comes to us, ये re-entry के लिए tachycardia हो रहा है, right? Re-entry के लिए tachycardia हो रहा है, but what is re-entry? Re-entry क्या है? Coming to it. So to understand re-entry, you need to see a picture. This. Okay. So here is picture A and picture B. Okay. Let us understand this very carefully. Okay. So you see all these cells, these are cardiac myocytes, heart muscles. Okay. So simply these are heart muscles. And you know, action potential once generated, it can travel from one cell to another, one cell to another, it can travel. ठीक है? And both the direction, दोनों direction में action potential travel हो सकता है. Okay? एक सेल है, इसके बाद सेल है, इसके पहले सेल है, तो यहाँ भी action potential travel होगा, यहाँ भी action potential travel होगा, right? Okay, so one cell to another cell through gap junctions, which is the physical attachment between two cells. Okay, which is the physical attachment between two cells, through gap junctions action potential can travel. So say for example this cell, it can transmit action potential here, 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 here in this way, and this cell, it can travel action potential, it can transmit action potential from this cell to this cell, this cell, this cell in this way. So action potential can travel left to right and also right to left. Bidirectional action potential can travel. This is normal, it happens. Now say for example किसी को थोड़ा mild heart attack हो गया या फिर acute coronary syndrome कुछ हो गया mild, ठीक है? फिर धीरे धीरे patient recover भी कर गया, right? Now few cells will be dead or any kind of pathology affecting cardiac muscle. ठीक है? कुछ problem हुआ है cardiac muscle में, कुछ disease हुआ है, जो भी है, ठीक है? Some cells are dead. Okay, So here you say these are dead cells. Okay, these are dead cells, clear, and these are normal cells, clear. Okay, now if I talk about action potential transmission from this side right to left, what will happen? So there are lots of normal cells, right? There are lots of normal cells, and these normal cells are sufficient to transmit action potential from right to left, करेक्ट. एंड ये जो डेड सेल है इनका कोई एक्शन पोटेंशियल नहीं होता है, इसमें गैप जंक्शन भी डैमेज हो गया, सब कुछ डैमेज हो गया, इट कैन नॉट ट्रांसमिट एक्शन पोटेंशियल. दीज आर डेड सेल्स, एब्सोल्युटली डेड सेल्स. ओके, फाइब्रस टिश्यू, राइट. नाउ हियर आर few living cells, only few normal cells. Now these normal cells are not sufficient to transmit enough action potential from this side to this side. Getting my point? So in this situation, action potential will travel from right to left, normal conduction, but conduction will be blocked from this side to this side. Clear? Either action potential will not travel or it will travel very slowly. You can consider a block there. Getting my point? Okay. So here lots of normal cell are able to transmit action potential from this direction to this, right to left, but these few normal cells are not sufficient to transmit action potential to the large number of normal cells on the right side. Okay, so here there is unidirectional block. Okay, action potential will travel from right to left, but left to right transmission is blocked. Clear everyone? If everyone is clear, then I can proceed to the next slide. Okay. So this unidirectional block is the basis of re-entry. Okay, this unidirectional block is the basis of re-entry. Basically, there are three prerequisites, three conditions that should be fulfilled for the re-entry to happen, right? Okay, now for re-entry to happen, I need to draw a picture for you. Draw a diagram for you. Okay, so there will be a circular path of muscle fiber, circular pathway of muscle fiber, right? So here is a circular pathway, right? Here is a circular muscle layer, circular path. Okay. Right. Okay. So three conditions that should fulfill, that are prerequisite to fulfill the re-entry, right? So number one is unidirectional block that I explained here. What is unidirectional block? Number two is presence of circular path. Okay. And number three is perfectly timed premature atrial complex. Okay. These three criteria are required for re-entry to happen. One is unidirectional block. Number two, हार्ट में कहीं पर भी ऐसा सर्कुलर पाथवे रहना पड़ेगा, राइट? एंड नंबर थ्री इज परफेक्टली टाइम्ड एट्रियल प्रीमैच्योर कॉम्प्लेक्स और प्रीमैच्योर एट्रियल कॉम्प्लेक्स. करेक्ट. नाउ री-एंट्री होता कैसे, राइट? सो देयर शुड बी in this circular pathway, one is slow path and another is fast path, right? स्लो पाथवे, अनदर इज फास्ट पाथवे. स्लो पाथवे कैसे होता है? ऐसे होता है, ठीक है. तो यहाँ पर दिस वन इज स्लो पाथवे एंड दिस वन इज फास्ट पाथवे. क्लियर? ओके. So now in heart there is a circular pathway and one path is slow, another path is fast. Do you have the concept of refractory period? As because nerve muscle physiology is already running. Refractory period. What is refractory period? Okay. So do you remember this action potential? Do you remember? It happens in cardiac myocytes. Okay. So once this action potential is happening, if I stimulate the cardiac muscle again, should this cardiac muscle receive the second stimulus or not? It depends on the refractory period, right? Say for example, this duration is 200 millisecond. This duration is 200 millisecond, right? Okay. So there is some stimulation here. That is why this action potential is here, right? Okay. Now if I stimulate here again, should there be another action potential here? No, because it is refractory. Okay, একটা action potential already চলছে, তার মাঝখানে সেলটাকে আবার ডিপোলারাইজ করা যায় না, right? One action potential is already running. I cannot stimulate it further, right? So if I stimulate it here, there will be no second action potential because the cell is in refractory period. ঠিক আছে, আমি অলরেডি ডিপোলারাইজড আছি, আমি আর ডিপোলারাইজেশন নেব না, ঠিক আছে. This is the thing. But up to this, okay, it is the absolute refractory period. Okay, this period is absolute refractory period, and during this duration the cell is not ready to take another action potential, right? During absolute refractory period the cell is not ready to take another action potential. After absolute refractory period the cell may take another action potential depending on the strength of the stimulus. If I apply a higher stimulus, the cell may take another action potential, right? May take another stimulus, right? So this is relative refractory period. Clear? This is relative refractory period. Okay. Now what happens in slow pathway and what happens in fast pathway? A slow pathway has a short refractory period, okay, and the fast pathway has a long refractory period, right? Slow pathway has short refractory period, and how to remember? Slow, SS, slow pathway, short refractory period, SS. This is how you may remember, right? And the fast pathway is having long refractory period. इसका refractory period ज़्यादा है. Clear? Okay. Now what will happen if an action potential is coming from above? What will happen if an action potential is coming from above? So action potential is coming here, okay, action potential or depolarizing wave. Clear? Okay. So action potential is coming from above. Here is a circular pathway. Now after reaching the top of the circular pathway, action potential यहाँ तक पहुँचा है, right? At this point. Now what will happen? इसके पास दो रास्ता है. What will happen? Action potential will travel through the both or what? Yes, action potential will travel through this pathway, Okay, because it has got short refractory period. उसका refractory period खत्म हो चुका है already. It is ready to take another action potential, right? But this path, fast path, is having high refractory period, long refractory period. It is not ready to take another action potential. Okay, so here is a block, right? So action potential cannot travel through the fast pathway initially. Okay, now this action potential, it travels and now it is reaching here at the lowermost point of the circle. Okay, at the lowermost point of the circular pathway. Now what will happen? Okay, so it takes some time to reach the lower part of the circle, right, of the circular pathway. Now by the time it reaches the lower part of the circle, the refractoriness of this pathway is gone, right? So this is why we need to meet three criteria: unidirectional block, presence of circular path, and perfectly timed premature atrial complex. इसका timing मतलब ऐसे adjust होता है, the timing is so perfect. Okay, so initially when the action potential is coming, it finds this refractory, it cannot travel through this, so it travels through the slow pathway, okay, with short refractory period. Now once it reaches the upper part of the bundle of His, right, now the refractoriness is gone. Okay, it is ready to take another action potential. Okay, इसका refractoriness अब खत्म हो चुका है, right? By the time it reaches here, now it can travel here, it can travel here. Clear? Okay. So now suppose the AV node is here. Here is the AV node. Correct? Here is the AV node. Now what will happen? This is your heart. Okay? Now this is AV node, and around this AV node you have this circular path. Clear? Around this AV node you have this circular path, जिसको मैंने large करके यहाँ पर present किया, right? Okay. So one impulse is coming from the atria. I repeat, one impulse is coming from the atria. There is a circular path, and at the upper part of AV node, this is the upper part of AV node, at the upper part of the AV node, when action potential reaches here, it finds two paths. One is slow path with short refractory period, another is fast path with long refractory period, right? Now once it is at the top of AV node, it finds the fast pathway is refractory, it is not taking any, it is not accepting any action potential, right? So it will travel through the slow pathway. Now once it reaches the upper part of the bundle of His or lower part of the AV node, okay, once it reaches the upper part of the bundle of His or the lower part of AV node, it finds the refractoriness of the fast pathway is already gone, and it is ready to accept another action potential. So action potential travels back through the fast pathway and also travels through the bundle of His towards the ventricle. Clear, everyone? Okay. So what will happen? This will depolarize the ventricle, and this will go back to atria, and this will go back to atria and depolarize the atria. Correct? Clear, everyone? Okay. So atria and ventricle, they are depolarized, they are being depolarized simultaneously. Normally क्या होता है? पहले P wave होता है. P wave is due to atrial depolarization. उसके बाद QRS होता है. QRS is due to ventricular depolarization. तो normally क्या होता है? P wave पहले, उसके बाद QRS complex. That means पहले एट्रिया डिपोलराइज होता है, उसके बाद क्यूआरएस माने वेंट्रिकल डिपोलराइज होता है, राइट। नाउ यहाँ पर क्या हो रहा है, बोथ एट्रिया एंड वेंट्रिकल दे आर डिपोलराइजिंग साइमल्टेनियसली, ओके। यहाँ पर एक री एंट्री हो रहा है एंड फ्रॉम दिस री एंट्री both atria and ventricle are being depolarized simultaneously, एक साथ, right? Both atria and ventricle are being depolarized एक साथ, clear? Okay, तो अब क्या होगा, how will be the ECG? P wave and QRS complex दोनों एक साथ अगर होता है तो किसका वोल्टेज ज्यादा है, P wave का वोल्टेज ज्यादा है या QRS complex का वोल्टेज ज्यादा है? QRS complex का voltage, because atria is thin, atrial muscle mass is less, okay, and ventricle is large, it has got a high muscle mass, right? So QRS complex का voltage ज़्यादा है, okay. So if you get P wave, one P wave and QRS complex एक साथ, right? So ideally P wave will not be seen, P wave is covered under QRS complex, right? P wave is covered under QRS complex and you are not able to identify P wave separately. You are not able to identify P wave separately. On the ECG, you see only QRS, 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 no P. Okay? See. So in this ECG, there is no P wave. What you find is QRS T, QRS T, QRS T, QRS T, no P. Correct? It is called AV nodal reentrant tachycardia, right? AV nodal reentrant, AV nodal reentrant tachycardia or AVNRT. AV nodal reentrant tachycardia, from reentry to reentrant. AV nodal reentrant tachycardia. That means there is a reentry circuit around the AV node. Okay, there is a reentry circuit around the AV node, and this is why atria and ventricle are being depolarized simultaneously, right? Atria and ventricle are being depolarized simultaneously. What you get in the ECG, only QRST, 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 no P. As because P wave is also happening, but P wave is so feeble, right? So weak that it is covered under the QRS complex. QRS complex का voltage बहुत ज़्यादा है, right? So it takes over. Okay. Now, if this is the ECG of the patient, what the patient will be having? Symptoms. Patient will be complaining of something. क्या complain होगा patient को? क्या problem होगा patient को? Cardiac arrest तो नहीं हुआ है because heart is beating. Only you are getting QRST, QRST, QRST. Very nice. Patient will be having palpitation. বুক ধরফর করছে, ঠিক আছে? Patient will be having palpitation. Okay. So this much is required for you for AV nodal reentrant tachycardia. Heart rate will be usually 150 to 250 per minute. Okay. इसमें heart rate होगा in this condition AV nodal reentrant tachycardia. Okay. AV nodal reentrant tachycardia, patient का heart rate होगा 150 to 250 and the symptoms, major symptom of the patient will be palpitation. This much is required for you. Treatment is not required for you. Yes, it will be required for you in subsequent time when you will be studying medicine in final year. You need to know the treatment as well. Okay. So I will not discuss treatment in details because it is not in your physiology curriculum. But for your interest, one or two lines, how to treat the patient. There are two options to treat the patient with this AVNRT or atrioventricular reentrant tachycardia. There are two options. One is non-pharmacological, that means without giving any medication to the patient. So we can do vagal maneuver, vagal massage. Okay. So you need to identify the carotid pulse, go above, and you need to massage the carotid area, right? Vagal massage. And with this maneuver, there is reduction in the heart rate. Vagus is parasympathetic, you know, parasympathetic supply, it can reduce heart rate. Okay. But very often in emergency or in ICU setup, patients present, and we do not wait for this because it takes time, right? It takes time, vagal maneuver. It can be performed at home, not in hospital setup. In hospital setup, usually the medication is available and we directly treat the patient with the medications, right? Okay. So name of the drug, क्या injection दिया जाता है patient को, that is also not required for you, just your interest purpose I am telling. The drug of choice is adenosine. Okay, the drug of choice is adenosine, the same adenosine what you study, adenosine monophosphate, adenosine triphosphate, right? Okay, so drug of choice is adenosine. It is an antiarrhythmic drug, right? Drug of choice is adenosine, and there are lots of things with adenosine because it should be injected with a central line, not in a peripheral line, because adenosine has got a very poor half-life. It breaks down immediately after injecting. Okay, so if you inject here in a cannula, in a venous cannula, if you inject here, so it need to move to heart to act, right? So यहाँ तक जाते जाते ही ये breakdown हो जाता है, right? So ideally it should be given through a central line in a saline chase method so that it can reach heart immediately and start its action. The dose is 6 milligram. Okay, anyway, these things are not required for you, and the dose can be repeated. Okay, 12 milligram, 6 milligram ऐसे dose होता है, अब maximum 50 milligram तक दिया जा सकता है. Anyway, these things are not required. Okay, so very briefly I am recapping what is re-entry for your question, for your first professional MBBS question, short note re-entry. Okay, or long question, what is re-entry, or it may be a case scenario like a patient is coming to the emergency department with the complaint of palpitation, you performed ECG and this is the ECG, what is the diagnosis and what is the basis of this, what is the physiological basis of re-entry, these things. Okay, these are the things. So if you were to write re-entry, then you need to explain the unidirectional block. So first you need to explain that for re-entry to happen, we need to fulfill 3 criteria. One is unidirectional block, second is presence of a circular pathway, and third is perfectly timed premature complex. Okay, and if the re-entry circuit is around AV node, it happens. Action potential is coming on the top of the AV node. It finds 2 pathway. One is slow pathway with short refractory period, another is fast pathway with long refractory period. And at the top of the AV node, as the fast pathway is refractory, it is not accepting any action potential. The action potential travels through the short pathway. And once it reaches the upper part of the bundle of His or lower part of the AV node, the refractoriness of the fast pathway is already gone. So action potential travels backwards towards the atria and also downwards towards the ventricle, and both atria and ventricle are depolarized or activated simultaneously. They beat simultaneously. Okay, atria and ventricle are depolarized simultaneously. As a result, the patient is having palpitation, and on ECG we find this, there is no P wave, and we get QRST, 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 because P wave is buried under the QRS complex. Both are happening simultaneously, right? Okay, in 75% cases it happens, but in rare situation it may also happen that P wave falls after QRS complex. So this is quite rare. Okay, this is quite rare. So you see this is QRS, okay, and after QRS we find the P wave. Okay, here is the P wave, here is the P wave. Okay, so this is very less. Okay, and most commonly we will see patients with AVNRT with absolutely no P wave. Okay, but in rare scenario P wave may fall after QRS complex. Okay, and we call it pseudo S wave. Anyway, not required for your level. Okay, now coming back to another thing. So can you see, we are moving from re-entry, we are moving to another condition. Here also patient will be complaining of palpitation, but the ECG will be somewhat different. You see the ECG, and can you tell me what is the abnormality in this ECG? What is the abnormality in this ECG? Anyone? Okay, you see P wave, this is P, and immediately after P you get QRS. Okay, ideally we have some PR interval. Okay, we have some PR interval from starting of P to end of Q to the beginning of Q, right? So that interval is reduced, and you know that when PR interval is increased we call it heart block. But here the scenario is reverse. PR interval is short, right? PR interval is short. P wave হওয়ার পরেই সঙ্গে সঙ্গে QRS উঠে গেছে। Okay, in normal scenario P wave হওয়ার পরে আমার কিছুটা গ্যাপ লাগে, right? So we have a P wave and there is a gap and then Q wave, right? So P, उसके बाद थोड़ा सा isoelectric line, then Q. Now here it happens P and then immediately QRS, right? Clear? So PR interval is short. Okay, so what is the cause of this short PR interval? Again, in this scenario the patient will be complaining of palpitation. Okay, patient will be complaining of palpitation. So see this, so forget this one and this one, first focus on the first picture. Okay, focus on the first picture. What is happening? What is happening here? Normally when so this is your heart, right? Okay, so action potential is being generated from here, the SA node coming to AV node, right? Then bundle of His, then right bundle branch and left bundle branch. This is how the action potential travels, the normal path. Okay, now in this scenario there is an abnormal path from atria to ventricle. The normal path from atria to ventricle is through AV node. ठीक है, एसओ नोड से जो इम्पल्स जनरेट हो रहा है इट मस्ट ट्रेवल थ्रू एवी नोड. एवी नोड होके ही इसको गुजरना पड़ेगा, राइट? इट मस्ट ट्रेवल थ्रू एवी नोड. एवी नोड होके ही जाना पड़ेगा, एक ही रास्ता है. आई कांट अवॉइड दिस, राइट? बट हियर इट इज एन एबनॉर्मल सिचुएशन where there is a special connection between atria and ventricle. Okay, there is a special connection. Here is the AV node, right? Here is the AV node. Okay, now the action potential, it can bypass this path, right? Action potential can bypass this path and it can travel through this abnormal path. Okay, AV nodal delay. Do you know what is AV nodal delay? AV node क्या है? चेकिंग है, पुलिस चेकिंग, नाका चेकिंग, राइट? जहां पर आपको रोकता है एंड इट चेक्स whether you are eligible to pass to ventricle. Ventricle is a sophisticated thing, ठीक है? वेंट्रिकल में जाने के लिए आपको एकदम क्लियर होना पड़ेगा, राइट? सो ऐसा नहीं, एट्रिया से रिदम इज बीइंग जनरेटेड फ्रॉम द एट्रिया. द फंक्शन ऑफ AV node is checking. I will check what the signal is coming from SA node. If it is okay, the signal is coming from atria. AV node is checking. I will check all the signal coming from atria. If it is okay, then only I allow to ventricle, because ventricle is sophisticated area. ठीक है? Special area, restricted area, right? सबका यहाँ पर घुसना मना है, right? So I will check all the signals coming from atria. I will check if I am AV node. I will check everything coming from atria and I will allow only selected signal to ventricle. This is the function of AV node, right? But here there is a bypass. There are some signals, okay, which are bypassing AV node and it is coming from atria to ventricle without checking, right? Because of this abnormal fiber, because of this abnormal pathway connecting atria to ventricle. Okay, for the checking process it needs some time. In AV node, if the signal is coming through normal pathway, at the AV node it needs some time. But if the signal is following the abnormal path, there is no checking. It is directly coming from atria to ventricle, right? So it is a security risk for the ventricle, right? It is a security risk for the ventricle. Okay. So, for the AV nodal delay, you get some PR interval. Now, once this delay is not there, atria to ventricle signal is coming directly through this pathway. Okay. Through this pathway, signal is coming directly from atria to ventricle through this abnormal pathway. This abnormal pathway is called the bundle of Kent, K-E-N-T, not water purifier, right? Okay. The signal is coming from atria to ventricle through abnormal pathway. This abnormal pathway is called the Kent fibers, okay, according to the name of the cardiologist, right? Okay. So, this is Kent fiber which transmits signal from atria to ventricle without checking, bypassing AV node, right? So, there will be ventricular pre-excitation. अगर नॉर्मल पाथ से अगर ये होता तो AV node उसको चेक करता कि whether the signal is correct or not, should I send it to ventricle or not, but here is no checking. So, atria to ventricle action potential fast travel हो रहा है, fast, without AV nodal delay, right? So, this is why here is a pre-excitation. बाद immediately QRS complex fire कर रहा है, right? Okay. So, there is no delay, or PR interval is getting shortened. Okay. Atrial depolarization, immediately ventricular depolarization. Normally, we have some delay between atrial depolarization and ventricular depolarization. We call it PR interval, right? Now, this PR interval is shortened. Atrial depolarization के बाद immediately ventricular depolarization. Okay. So, this is the slurred upstroke due to premature or excitation, due to premature excitation of the ventricle. Ventricle पहले से ही excite हो रहा है. Okay. Ventricle is being excited quite before than it is supposed to be, right? So, pre-excitation of the ventricle gives rise to this specific shape of QRS complex. Okay, you see this P wave, immediately QRS complex, and you see the QRS complex is widened. Okay, QRS complex is widened. Okay, wide QRS complex. When we call it wide QRS complex, when more than 120 milliseconds. Okay, more than 120 milliseconds, we call it wide QRS complex. So, here it is wide QRS complex. Again, the patient will be having palpitation, right? And if you perform ECG, if you find this in the ECG, it is called WPW syndrome. Have you heard of this? Have you studied this in your book? Okay, it is called WPW, Wolff-Parkinson-White syndrome. WPW syndrome, right? Okay. So, there is something to tell that this fiber is present from the very beginning, from childhood. It is a congenital condition. Janmagato thake, if the abnormal fiber or Kent fiber is present, right? Again, treatment is not required for you. Usually, the treatment is done by laser ablation. Okay, so we apply laser ablation, okay, or radio ablation, and we destroy this abnormal tract, right? It is usually done by the interventional cardiologist, right? Okay, so this abnormal pathway or Kent fiber is ablated by laser. Okay, laser ablation of this abnormal fiber. This is the treatment. Okay. Okay, very often it is seen that this abnormal path is present, but there is no flow of action potential through this. Then the patient will not be having any symptoms. Okay, even the ECG will be normal if there is no flow through this abnormal path. Okay, the patient will only have symptoms when there is flow through this abnormal pathway. There is flow of action potential through this abnormal pathway, and then only you see this manifest WPW. We call it manifest WPW. That means the patient is having symptoms. Okay, the patient is having symptoms. We call it manifest WPW. And if the Kent fiber is present and there is no changes in ECG or the patient is not having any problem, we call it concealed. Okay, concealed WPW syndrome. Okay, if it is concealed WPW, you need to follow up the patient. You need to perform ECG every 6 months or every 3 months. so that you can detect earliest the diagnosis, right? You can detect the patient at the earliest. Okay, then only then you can treat the patient accordingly by laser ablation or radio ablation of the tract abnormal fiber. Okay, so this is called WPW syndrome. Again, WPW syndrome is a short note for you in your first professional MBBS, or it may be asked in the Viva as well. Yes, it is congenital, জন্মগত, ঠিক আছে? Correct? And end fiber is nothing, it is just a modified myocardium. Okay, it is just modified myocardium. So there is no AV node, so definitely it can transmit action potential faster than it's supposed to be, right? Okay. Now another two things. So initially we have seen this abnormal pathway or the bundle of Kent abnormal pathway or the Kent fiber, it can behave as a reentrant circuit as well, right? এতক্ষণ WPW syndrome যেটা ডিসকাস করলাম, there was no re-entry, but this presence of this abnormal fiber, it can behave as a re-entry circuit. Okay, and action potential, two things can happen. Action potential can travel atria to ventricle through normal pathway, and it can go back to Kent fiber. So it is a re-entry circuit, atria and ventricle. Getting? It is a re-entry circuit. Action potential is coming from atria to ventricle through normal pathway, and it is moving back through abnormal pathway. Clear? So coming through AV node, normal pathway, going back to atria through Kent fiber, abnormal pathway. We call it orthodromic AVRT. This is called AVRT, not AVNRT. पहले हम लोग जो डिस्कस किए थे, that is AVNRT, AV nodal reentrant tachycardia. Now it is atrioventricular reentrant tachycardia, AVRT, right? So here is a big reentry circuit. पहले एक छोटा सा reentry circuit था around AV node, right? Around AV node we have this छोटा सा reentry circuit. Now we have a big reentry circuit, right? Big reentry circuit. This is the reentry circuit, and you see the electrical impulse or depolarization wave is coming through normal pathway, going back to atria through abnormal pathway. We call it orthodromic AVRT, right? Orthodromic AVRT. And another problem is just the opposite of that. The action potential is coming from atria to ventricle through abnormal pathway or the bundle of Kent, right? And it is going back to atria through normal pathway, and it is called antidromic AVRT. Okay. Anyway, these things are difficult for you. Nobody will ask you to identify an ECG with orthodromic AVRT or antidromic AVRT. Just you can write under re-entry these two things as well, because re-entry circuit may cover atria and ventricle as a whole, a big re-entry circuit covering both atria and ventricle, and a small re-entry circuit around AV node that may create a small re-entry circuit around AV node, and that may create AVNRT, AV nodal reentrant tachycardia. Okay, so basically re-entry you can divide into AVNRT and AVRT. Okay, re-entry is divided into AVNRT and AVRT, right? AVNRT we have already discussed over here, and AVRT is divided into orthodromic AVRT and antidromic AVRT. In orthodromic AVRT, the action potential is moving through normal pathway, going to ventricle and coming back to atria through abnormal pathway, and in case of antidromic, action potential is coming through abnormal pathway and going back through normal pathway, right? Okay, and remember, this is more serious, this antidromic AVRT, because it has got wide complex tachycardia. Okay, it has got wide complex tachycardia, and adenosine will not work here. If you give the patient adenosine injection, it will not work because it is wide complex tachycardia, and usually different types of antiarrhythmic drugs is used. Nobody will ask you, procainamide is the drug of choice. Okay, it is class 1 or class 3 antiarrhythmic, I guess. Okay, nobody will ask you treatment for your level for first professional MBBS. The questions are WPW syndrome, then re-entry in details. Okay, what is re-entry, how does it work, what are different types of re-entry, what is its physiological basis, and WPW syndrome. Okay, these are questions for you, ekdam core questions. It will be coming in the theory exam as well as it will be asked in your Viva as well. Okay, and you need to identify ECGs with WPW syndrome. Okay, you need to identify ECG with WPW syndrome. Okay, identifying AVNRT is tough, but still may be given if you are doing well. Okay, chalo, thank you.